So hi everyone, I'm Akash. I run Mind the Bleep, but I also am a ST3, ST4 now actually, endocrinologist, working in both endocrine and diabetes. So that's a picture of me looking much happier and healthier before the COVID pandemic. And the topic that I'm going to be giving is on thyroid emergencies, specifically focusing on myxoedema, coma, and thyroid storm. I look forward to plenty of questions, so please do send them through. And you can also access my website, Mind the Bleep, for a little bit more material on thyroid stuff. So this is what we're going to be going through. We're going to be going through thyroid axis because really to understand the emergencies, you need to understand the bare basics of how the thyroid works. Then we'll go through hypothyroidism and the associated emergency, which is myxoedema coma, and also hyperthyroidism and the associated emergency, which is the thyroid storm. So the first thing to focus on is thyroid dysfunction. There are lots and lots of symptoms that alert you to somebody's thyroid not being quite right. So there's hypothyroidism when the thyroid is underactive and hyperthyroidism where it's overactive. In underactivity, because your thyroid predominantly looks after your metabolism, you feel tired, you feel cold, you gain weight, you can get constipated if you menstruate. Your periods are much irregular and heavy, and you get bradycardia or a slow heart rate. With hyperthyroidism, you get the exact opposite. You're energetic, you're hot, you're losing weight, you've got diarrhea, you're tremulous, your periods can become infrequent, and your heart races like anything. What's important though is if you look at these symptoms, particularly things like tiredness and cold and feeling hot, either weight gain or loss or a bit of changes to your bowel habits, that's pretty much all of us, isn't it? We've had one of these symptoms in the last few months. And so you'll find pretty much that everyone gets their thyroid measured because the thyroid can cause any number of different pathologies. So if you're ever thinking, should I measure the thyroid function test? The answer is usually yes. The other reason why we need to measure it so often is because of how common the problems are. So for hypothyroidism, this is incredibly common. About 10%, 5 to 10% of the population out there have an underactive thyroid, causing all of those symptoms we just described. Hyperthyroidism, in contrast, is a lot more rare, 1 in 1,000. And it's all to do with this. This is the thyroid axis. You've got 3 hormones to look at. That's TSH, T3, T4. TSH is thyroid stimulating hormone. It's the hormone produced in the pituitary gland near the brain, which basically does exactly what it says, thyroid stimulating hormone. It stimulates the thyroid to produce hormone. The thyroid produces T3 and T4, which are your active thyroid hormones. If they are high, you have hyperthyroidism. If they are low, you have hypothyroidism, as simple as that. And this is an important thing to appreciate. So the TSH will stimulate the T3 and T4. To prevent things going round and round and round and too much T3, T4 being produced, there's a negative feedback loop, which says, if the thyroid produces too much T3, T4, can you please shut off the TSH production? But conversely, if it doesn't produce enough, the TSH will produce more and more and more. The idea is to keep the T3 and T4 in the right balance. And so in hypothyroidism, we'll have a low T4. In hyperthyroidism, we'll have a high T4 and T3. We don't tend to measure T3 all the time, which is why I've said T4 and T4/T3 for hypothyroidism. Conversely, the TSH will be the opposite because when in most conditions, it's the thyroid that's the issue. The thyroid itself is the problem. And it's either producing too much or too little hormone. And so the pituitary gland or in the brain will try and either get it to produce more or get it to produce less. So in hypothyroidism, the patient has a low T4. And so the pituitary gland is producing lots of stimulating hormone to try and to stimulate the thyroid to producing more T4. So TSH is high. In hyperthyroidism, the opposite is true. The thyroid gland is producing so much of this T4, T3 that the pituitary gland is saying, no, stop, by reducing the amount of stimulating hormone. Primary hypo and hyperthyroidism is by far more common than any other type. Over 95% of cases, and that means actually a massive population of hyperthyroidism if we take into account how rare it is. In passing, I'll mention secondary hypo and hyperthyroidism. This is where actually the pituitary gland is at fault, where the pituitary gland produces too much TSH. And if it does, then you're going to produce too much T4, T3. So hyperthyroidism, i.e. there's too much stimulating hormone. In hypothyroidism, it's where the pituitary gland stops working, so it doesn't produce the TSH, and so the thyroid doesn't produce the T4. But this is vanishingly rare and not something that you're going to really see in day-to-day practice, because I very rarely see it, even working as an endocrinologist. Subclinical disease is something that you'll hear from time to time, because that's quite common. Subclinical is where things have just started but haven't gone into full-blown mode. So in hypothyroidism, in proper hypothyroidism, again, as I said, your T4 is very low, the active hormone is low, and your pituitary gland is trying to push. Well, if your T4 is in normal range, but your pituitary gland is having to work really hard to achieve that, we call that subclinical hypothyroidism, i.e. that your thyroid, the active hormones are in normal range, but your pituitary gland is having to work hard to achieve that. Similarly, if your T4 and T3 are normal range, but your pituitary gland is basically producing no hormone to achieve that, it's because your thyroid is producing a bit too much. And so the only way the body can get it back into normal range is by not producing any extra TSH. That's subclinical disease, and that's another kettle of fish. It's just something to be aware of out there. So, hypothyroidism. Well, hypothyroidism is quite a simple entity. Essentially, for most people, it's caused by autoimmune destruction of your thyroid gland. And so, over 90% will have positive TPO antibodies, and universally, Hashimoto's thyroiditis is the most common cause in kind of first world countries. In third world countries, iodine deficiency and other things are there. We don't tend to measure TPO antibodies, to be honest, because we know it's so common that actually we just assume everyone has it. The only time we do it is if we're thinking this patient's kind of borderline hypothyroid or subclinical hypothyroid, where the TSH is up, but the T4's in normal range. At which point we will measure it to basically say, well, you're actually quite likely to develop hypothyroidism, so I'm going to check your thyroid test every year. Otherwise, if the TPO antibody was negative, we'd actually only measure it every 3 years, because we know it's very unlikely that they'll develop hypothyroidism. Treatment is simple. We basically just give T4 or levothyroxine, and it's about 1.6 micrograms per kilo that the average patient will need. Myxoedema coma is where you've got hypothyroidism, but it's become very, very severe. So we call this decompensated hypothyroidism. It's got a very high mortality associated with something between 40 to 60%. Fortunately, it's very, very rare. The reason being is because of how frequently we measure thyroid tests these days. It's very common that we'll pick up somebody with hypothyroidism very early on. We will treat it, and so they'll never get to the point where they have had months not receiving any treatment, to the point where they develop myxoedema coma. Myxoedema coma, you can think of it, as I said, as decompensated hypothyroidism. So everything you think of when you think hypothyroid and underactive thyroid, so they are slow and cold and tired, but everything just in that much more of an extreme case. So they are not just tired, they're drowsy. They're not just cold, they're hypothermic. They're properly bradycardic. They can get hyponatremia, hypoglycemia. Essentially, their body is kind of shutting down to the point where they get very drowsy and actually as much as a coma, hence the name. This tends to be precipitated by stress, essentially something which has basically told the body, I want you to work a little bit harder. And the body goes, no, I can't do this. I've been working so terribly for so long already. And now you've gone and given me a heart attack, or I've had some surgery or an infection. I cannot manage. I'm just going to sleep like this lovely cat on the right-hand side. This is an emergency. If you see somebody or suspect somebody with a myxoedema coma, you're going to admit them to ITU. But I don't think that actually you need to know that they've got a myxoedema coma to make that judgment. My point is, if you saw somebody who was very drowsy and almost comatose, you're going to admit them to ITU regardless of whether you think or don't think they've got myxoedema coma. Once they make it to ITU, we're going to treat them with intravenous T3 and T4 hormone because we really want to kickstart their metabolism. We're also going to give them some steroid cover, so hydrocortisone, because we know that there's always that risk that it's not just their thyroid gland that's the problem, it's their pituitary gland. And if we kickstart their metabolism with T3, T4, we might actually push them over the edge where if they don't have enough cortisol, enough stress hormone. And so we give them that on top, just in case. Because T3 and T4 push your body to work harder, there is always that risk of arrhythmias and MI. And so that's another reason for them to be in ITU. It means we can watch them very, very carefully. So just to go over that again, myxoedema coma is when basically hypothyroidism, but gone way, way on too long to the point where they become comatose, drowsy, very, very cold, puffy, and have hypoglycemia. We're going to admit them to ITU. We're going to give them IV hormones. We're going to give them IV stress cover as well with hydrocortisone, and we're going to monitor them very, very, very carefully. Next up is hyperthyroidism. So hyperthyroidism is again most commonly caused by an autoimmune condition called Graves' disease. In Graves' disease, what you have is you have got TSH receptor antibodies. In other words, that receptor where the thyroid stimulating hormone would normally sit and tell the thyroid produce more hormone, well, the body's produced some sort of antibody which targets that and basically turns the thyroid gland all the way to max. So it produces too much hormone. There are other conditions as well that can cause hyperthyroidism. Another is viral thyroiditis, also known as de Quervain's thyroiditis, which is when a patient can get a bit of a viral infection and their thyroid gets stressed out and produces too much hormone transiently, that this spontaneously resolves after a few weeks and doesn't really need much treatment, just supportive treatment to manage the fast heart rate like a beta blocker. And then finally, you can have a little nodule or a couple of nodules in your thyroid gland, which for whatever reason have decided that they're not going to listen to the rest of the body and they're just going to start producing lots of hormone. In this case, the TSH receptor antibody would be negative, i.e. the antibodies would be negative, prompting us that there might be another cause going on. Whatever the cause, actually the cause doesn't make much difference, because unless it's viral thyroiditis, where it's normally quite obvious, they've got a raised CRP, they've got a tender thyroid. If they don't have that, then we're going to treat them with carbimazole, because what that's going to do is that's going to block the thyroid from producing hormone. So it doesn't matter what the cause and why they're producing too much hormone, we are going to protect them from doing that by giving them medication that stops their thyroid from overproducing this hormone. Thyroid storm is basically just like hypothyroidism causing myxoedema coma. Thyroid storm is like the hyperthyroid crisis. It's severe hyperthyroidism where your body is producing so much hormone that your metabolism is so high to the point where it actually makes you very, very unwell. Again, this is often caused by a stressor of some sort, like trauma, particularly to the thyroid gland, infection, or surgery, again, particularly to the thyroid gland, where the thyroid then gets a bit upset and stressed and just overproduces hormone. And so It's the exact opposite of myxoedema coma. You are pyrexic, you are feverish, your heart's racing, you're agitated, you often have psychosis, so you're confused, seeing things, you get diarrhea, and your heart can work so hard that you can get to the point where you actually get heart failure. It can be difficult to pick up when a patient, so usually quite obvious when a patient's hyperthyroid, because you look at them and you're like, oh my gosh, you look like the most stressed person in the world, and every part of your body is working like 20 times harder than it should. But thyroid storm, it can be difficult to work out when a patient's got thyroid storm. And so what we use is we use the Birch-Rutowski score. The Birch-Rutowski score is basically a way of looking at all the different systems that excess hormone can aggravate, and basically totting them up. Has the patient got a high temperature? Do they have CNS effects? Like, are they agitated? Do they have seizures? Do they have a coma? Do they have the GI side effects? So are they producing lots of loose stool, diarrhea? And do they have jaundice? Is their heart rate really high? Is their heart working so hard it's failed, or it's fibrillating? And then finally, is there a precipitating event that could, again, support the fact that this is likely a thyroid storm? You basically score up the patient, and you can go on MD Calc, or you go on anything to work out the score. And if that score is more than 45, you're thinking a thyroid storm is quite likely. More than 25, you're thinking maybe this is a thyroid storm. Whatever the case, though, if the patient's starting to get some of these things, you're going to want to discuss with an endocrinologist, because they're going to need urgent treatment. If they've got a full-blown thyroid crisis, this is the treatment that you're going to give them. You're going to give them a beta blocker, because that's going to really nicely bring down their heart rate, bring down their agitation, and bring down all that extra stress that they're getting. The next thing you're going to give them is propylthiouracil. This is like carbimazole. What it does is it blocks the thyroid from producing too much hormone. Other things you can give are iodine. So weirdly, by giving them iodine, and you have to give them iodine a little bit into having the other two drugs, it basically stresses the thyroid out to the point where it doesn't produce any more hormone. You can also give steroids, because steroids will also reduce that the ability of the thyroid to produce too much hormone. And then the final thing we can do is give them what we call bile acid sequestrants. This works by, so normally thyroid hormones are recycled in the gut, and so we can basically make them poo the thyroid hormones out by giving them something like this. I am sure that is a lot of information, and so what we're going to use, we're going to use some case-based discussions to really understand all the underpinning messages behind all of this. So the first case that I'll take you through is Mrs. Anderson, who is a 36-year-old female. She is presented to a GP with subclinical hypothyroidism. So as I said before, this is when the T4 is in normal range, but the TSH is high. What this means is that the hormone is in the normal range, but the thyroid gland is having to work, well, the pituitary gland is having to work a little bit harder to push the thyroid gland into producing the right amount of hormone. Eventually, the TSH will go up and up and up and up and up as it keeps trying to push the thyroid gland to produce more and more and more and more, and eventually it will get to the point where it fails to do this, at which point you get hypothyroidism. And so she's got positive TPO, which supports the beginning of what we called Hashimoto's thyroiditis. And so we do annual thyroid function tests, and the next year we find that the patient is now decompensated. Their thyroid gland is, despite the TSH going up and up and up, the thyroid gland is not producing enough. You see the normal range here below, T4 of 11 to 21 and TSH 0.5 to 4.5. But what I want you to take away is that the TSH has gone up. TSH has gone up, and despite it going up and saying to the thyroid, I'm stimulating you, the thyroid is saying, I can't produce much more. And so at that point, we then start levothyroxine to basically take over the thyroid's job and give the hormone artificially. This is beautiful. It works. The patient's so much better. They feel so much better. They don't feel cold. They don't have that weight gain, that constipation, and all things are very, very good until 50 years down the line. So when Mrs. Anderson gets a lot older, she develops a number of comorbidities, including dementia. As a result, she forgets to take her medications for many weeks to months. Suddenly, because she's not been getting her post and her neighbours are worried about her, somebody eventually calls the ambulance services to find out what's happening. And so the ambulance services come and they find that she's very drowsy, she's hypothermic, she's bradycardic, and she's hypoglycemic. At that point, even if you didn't know it was a Myxoedema coma, you're going to be very worried. You are going to take this patient very, very quickly to hospital, where you're going to say, I think they need to be admitted to ITU, at least go to Restas. And that's where we will then do a number of tests, hopefully including thyroid function tests, where we will pick up the fact that it's this. It would be reasonable for her to have a CT head as well. And this is just the basic workup that we would do for any patient like this. And when we eventually find that she's profoundly hypothyroid, we're going to admit her to ITU because we're going to warm her up. We're going to give her some fluid replacement. We're going to give her some intravenous thyroid replacement, IV hydrocortisone. You should suspect this when your patient is known to be hypothyroid. So are there some tablets around of levothyroxine which they don't seem to have taken? Or you should suspect this when your patient is very drowsy, very cold, hypoglycemic, also hyponatremic, and things are just not looking quite right. Which, to be honest, is a lot of patients. A lot of patients come in drowsy and hyponatremic. This is just another test on the radar to just keep in mind. But it's very, very unlikely that it's going to be this. On the flip side, we've got Miss Rodney. Miss Rodney is the 35-year-old female who presents to A&E with pyrexia, with agitation, with diarrhea, with tachycardia, atrial fibrillation. If you saw these things, your first instinct would be, could this be an infection? And I think that's very reasonable. So you're going to send off a whole infection screen. You're also going to send off thyroid tests because you kind of see the tachycardia and the atrial fibrillation or the agitation and the diarrhea. But ultimately, pretty much every patient who comes to A&E should have a thyroid function test because half the time, as in if they're being admitted, half the time they've got one symptom of either hypo or hyperthyroidism. And you're going to treat them with some IV fluids. You might give some antibiotics because you're concerned there's an infection. Whilst waiting all of this, you finally get the thyroid function test back, and then you see they are very, very, very wrong. The TSH is basically non-existent. The T4 is through the roof. This patient's thyroid gland is clearly working way, way, way too hard. We can confirm this by doing a Birch-Rutowski score, and her score is 60. Above 45, suggesting a thyroid storm. So let me take you through that. So this is the Birch-Rutowski score. Her temperature is high, it's 38.1, and so she scores 10 points for that. Her CNS effects, well, she has got agitation. In terms of your GI and hepatic dysfunction, she's got diarrhea. Her heart's really fast at 130. She doesn't have any features of heart failure. She does have atrial fibrillation. And we're not sure if there was a precipitating event, but in total, she scores 60, which tells us this is a likely thyroid storm. So we need to urgently treat her. The initial treatment is going to be propranolol, it's going to be propylthiouracil, and hydrocortisone, all targeting basically getting that thyroid well under control as soon as possible. So the propranolol not only reduces the heart rate, but it actually interferes with the kind of conversion from T4 to T3. It basically impacts our thyroid to be able to do what it normally does. And so it actually has anti-thyroid activity. Propylthiouracil blocks the thyroid from producing excess amount of hormone. It takes a little bit of time to work, but by that time the propranolol should have worked. And then finally, we're also giving hydrocortisone, because once again, this reduces the ability of the thyroid gland to produce too much hormone, but also from converting it to the highly active form. The other things that you could consider are iodine and cholestyramine. But ultimately, the things to take away is if you've got a patient with a thyroid storm, what you're going to do is you're going to call your friendly endocrinologist and say, help. In the meantime, we'll send off some TSH receptor antibodies to decide whether there's a chance that this might be Graves' disease. Because if it is Graves' disease, that just gives us a little bit of an idea of how long this patient's going to need treatment for and what the next kind of steps are going to be. So just going back over a couple of things, just so that we're happy that we've gone over it. So we've got hypothyroidism, subclinical hypothyroidism, and we're measuring the thyroid function tests every year to the point where we discover the patient's got hypothyroidism. The TSH is now much, much higher, at which point we start levothyroxine. If your patient stops taking it for a number of weeks, and usually a number of months before you develop myxoedema coma, you will find that your patient's very drowsy, very hypothermic, very bradycardic, at which point you'll bring them in, they'll go to ITU, and one of the tests that we need to send are thyroid function tests. And if they are abnormal, we're going to call our friendly endocrinology team to start some intravenous thyroid replacement as well as steroids. Similarly, if a patient comes in very agitated, unwell, tachycardic, we're going to do a score to see could this be a thyroid storm. We're going to send some thyroid function tests, and then once again, we're going to call our friendly endocrinology team to work out what the next steps are, which would include propranolol, propylthiouracil, hydrocortisone, or steroids, to block the thyroid from producing too much hormone. And that is pretty much a summary of hypothyroidism, hyperthyroidism.